Dear students, hope you are taking care of yourselves and your family members during these difficult COVID times. I'm sure very soon we will overcome all this particular difficulty and come out. Normalcy also will be restored soon. Today, I'd like to talk about tinnitus and then take up vestibular disorders. What is tinnitus? Tinnitus is nothing but noise or ringing sounds in the ears. It may be unilateral or bilateral, and it may be of various levels of pitch and loudness. It may be like hissing, clicking, roaring, and whatnot. Any type of sound may be had. It may be subjective or objective. What is the difference? Subjective tinnitus is patient himself or herself will feel it, whereas objective tinnitus is heard outside. The listener, the examiner or family member also can hear it with some aid like a stethoscope or even sometimes without it. So what are the causes? Usual causes of subjective tinnitus, we can divide them as autological and non-autological causes. What are the autological causes? First and foremost is impacted sediment, secretory otitis media, suppuratory otitis media, both acute and chronic, and venous disease, most important, and presbyocusis, once again very important, noise-induced hearing loss, and sudden sensory neural hearing loss. Last but not the least, acoustic neuroma. Whenever we see a patient of unilateral tinnitus or unilateral sensory neural hearing loss, you cannot brush it aside just like that. We have to evaluate. Probably the patient must be having an acoustic tumor. Now, the important non-autological causes, they include anemia, thyroid disease, both hyperthyroidism, hypothyroidism, both hypertension and hypotension, head injuries, with particular reference to fractured temporal bones, and ototoxicity. Notorious drugs are aminoglycoside antibiotics. What are aminoglycoside antibiotics? Is streptomycin, caramycin, kanamycin, tobramycin, which we use in our daily practice. Not only such diuretics like furosemide, ethacranic acid, etc., and some antiepileptic drugs. Sometimes there may be the drugs like even these particular certain drugs which we use for pain relief also might produce ototoxicity. The cardiac diseases, many cardiac diseases and the renal diseases, they also can produce tinnitus. And last but not the least, psychogenic tinnitus. This is most important. Now, coming to objective tinnitus, the objective tinnitus may be pulsatile tinnitus, very classically seen in Bromus-Jubrate tumor. That means the tinnitus, the sounds in tinnitus will be corresponding to pulse. Very, very classically seen in Bromus-Jubrate tumor. What is Bromus-Jubrate tumor? Bromus-Jubrate tumor is a histologically benign but potentially malignant tumor seen in jugular foramen region and biliary cavity characterized by pulsatile tinnitus and fleshy pinkish polypoidal swelling. The histological features are, they are for the non-chromaffin paraganglionic cells near the jugular vein and corrector. Of course, there are other glomus tumors also, like the nail bed and all, other parts of the body also. And the carotid aneurysm also can produce tinnitus. And the venous hum, we can apply your stethoscope and see, notice the venous hum. And very commonly, these abnormal patterns in the eustachian tube. In each breathing, patient will hear the sounds. And last but not the least, the palatal myoclonus. Very classically, it will produce a clicking sound like a clock, which is heard outside. Very rare. How will you treat? Treatment is first evaluate and treat the cause. Most of the times, it is idiopathic in nature. The cause will not be known. In such individuals, reassurance is most essential. All these individuals are psychologically depressed and they feel very, very sad about their condition. They cannot concentrate on anything. So we have to advise them to relax, and we have to introduce some biofeedback procedures so that they can relax. Yes, tranquilizers we can give, especially the benzodiazepines. More especially the alprazolam has very strong effect on these individuals. Generally, it is given as 0.25 milligrams at a time. We can increase it up to 2.5 milligrams. It acts wonderfully well. And you can use some masking effects like using a fan or a watch, which will rather conceal the tinnitus. Of course, there are what are known as tinnitus maskers. They look like a hearing aid. They also produce noise. The noise will be matching with that of tinnitus, so that patient will not be feeling these particular ringing sounds which are troubling. And there is what is known as tinnitus retraining therapy, TRT. What is tinnitus retraining therapy? This is the tinnitus habituation by weakening the connections between the auditory nerve and limbic system and autonomic systems. This limbic system is concerned with emotions of our body, whereas the autonomic nervous system is also concerned with several actions like insomnia and all. Now we have to disconnect or weaken the connections between the auditory system and these two systems. So, how will you do it? First of all, habituation of reaction. This is done by uncoupling the auditory system and the limbic system. And then habituation of tinnitus. Patients should learn to live with tinnitus. That is, by blocking the tinnitus-related neuronal activity from reaching the level of consciousness. Patient should learn to ignore it. So the therapy consists of counseling, careful counseling, and sound therapy. So this is what is known as tinnitus retraining therapy. This is the tinnitus is a very, very refractory subject which doesn't respond easily to treatment. Sometimes patient are so depressed, they even go to the extent of attempting suicide. So all these tinnitus patients must be very carefully treated, reassuring them, take psychiatrist help, take audiologist help, and treat them. Coming to the vestibular disorders. You know very well, vestibular labyrinth is a part of the inner ear which deals with the balance of the body. Now, it is very apt to recollect our physiology of balance, how balance is maintained in the body, in the human beings. In the human beings, there are three systems that are concerned with maintenance of the balance. They are, number one is visual, the eyes. Number two is proprioception, that is sensation from the joints and ligaments. And the last but not the least, the vestibular labyrinth. Some people call the maintenance of equilibrium by vestibular labyrinth is a sixth sense. Some people say the vestibular sensation is very poorly developed in human beings when compared to lower animals. But still it is important. Now, how does eyes help in maintaining the balance of the body? That is by orientation and balance. They are maintained by several properties of the eyes, like what are known as saccades, smooth pursuit, optokinetic reflex, depth perception, and property of the visual cortex. What are saccades? They are jumping movements of the eye to bring the objects into the fovea. Suppose there is an object, suddenly from one place to other, if you see something directly, suddenly you have to see something else, the eye should move. This is called saccades. By means of saccades, the balance is maintained. And smooth pursuit. What is smooth pursuit? Smooth pursuit is smooth movement of the eye. If you show a pencil, eye will be moving smoothly to pursue this particular object, so that the object is brought to the fore. Now, optokinetic reflex. What is optokinetic reflex? Optokinetic reflex also same thing like smooth pursuit, but the object is too much, very big in size. Like, say, in case of the moving train, where we see a lot of things. So, this is optokinetic reflex. And depth perception, we have got binocular vision. What is the advantage of binocular vision? You can as well manage with single eye, but binocular vision helps in depth perception. You can identify the depth of the particular thing which you see. And not only that, the visual cortex centers, they are specially designed to respond to vertical and horizontal stimuli, something like global positioning system. Coming to proprioception, that is the joint sense and the sensation from the ligaments and all, and muscles. It contributes in the form of, number one, deep tendon reflex. Number two, by means of functional stretch response. We know very well what are deep reflexes and superficial reflexes. Now, this functional stretch response is nothing but it is controlling the muscle length by muscle contraction. And there is what is known as cervical proprioception. It includes a cervical ocular reflex, so that the balance is maintained. This is the picture of vestibular apparatus. This is the picture of membranous labyrinth, and the snail shell. The structure in the form of a snail shell is cochlea, and the remaining part with these half circles is this is vestibular labyrinth concerned with balance. This is cochlear labyrinth concerned with hearing. Even though they are interconnected, now in the vestibular labyrinth we have got utricle, the saccule, and 3 semicircular canals. The anterior semicircular canal, otherwise known as superior semicircular canal, horizontal semicircular canal, otherwise known as lateral semicircular canal, the posterior semicircular canal, otherwise known as posterior vertical semicircular canal. The semicircular canals, what is the function of the semicircular canals? It is Professor Berni who has described the semicircular canal for the first time and described the action, physiological action, for which he was awarded a Nobel Prize. They are concerned with response with angular acceleration. The utricle and the saccule, they are concerned with linear acceleration, whereas semicircular canals, they respond to angular acceleration. Various movements of the head, like this is called the pitch. This is called roll. And this is called roll. This is tilt. So these movements, they are, even though we do those movements, still are not imbalanced because my inner ear is functioning normally. And you know very well, in the erect position, so-called horizontal semicircular canal is not perfectly horizontal. It is about 30 degrees to the horizontal. And they are all paired. The horizontal semicircular canals are in the same plane, whereas the right posterior semicircular canal and left anterior semicircular canal on the same plane, whereas the left anterior semicircular canal and the right, left anterior and right posterior, left posterior and right anterior, they are in the same plane. Now, there are what are known as Otolith organs in the utricle and saccule. They contain calcium carbonate crystals. They are of very high density. So, with simple movement, they produce nerve impulses. And as I already mentioned, they respond to linear acceleration, that is gravity. And how does the vestibular labyrinth help in maintaining the balance? By means of certain vestibular reflexes. The first reflex is called is vestibulospinal reflex. See, this individual was sitting in the middle of this particular couch. When it is tilted, automatically his body has attained a vertical position, even though his eyes are closed. That means the vestibular labyrinth has helped him to attain this posture. So, this vestibulospinal reflex maintains the center of gravity. And in the same way, see this vestibulo-ocular reflex, the vision also helps in maintaining the stability of the visual field. And as a result of that, sometimes it will produce physiological nystagmus. What is nystagmus? To and fro, horizontal or vertical movement of the involuntary movement of the eyeball. And last but not the least, there is one more reflex called vestibulocervical reflex. Even though, see, this bird its torso is here, and it made 90 degrees tilt, 90 degrees rotation of its head. Still it is in the balance. So it is the vestibular cervical reflex that maintains the balance. Now what is vertigo? Vertigo is nothing but hallucination of movement. In other words, it is called false sense of movement with respect to surroundings. It may be called dizziness, or it may be called unsteadiness. Sometimes if it is too severe, there may be a drop attack. Suddenly the patient may fall down without any aura and all, unlike epilepsy. Now you have to do the balance function testing carefully to attain a reasonable diagnosis. How do you do it? History, history, history. History is the most important tool in evaluation. If you spend time with the patient and if you evaluate properly, automatically the diagnosis will be at your hand. If you ignore history, whatever examination you do subsequently, you may not reach a reasonable conclusion. And you should see that the patient himself or herself describe the symptoms on their own. Let them define and describe the so-called vertigo. Don't know, you may be dealing with syncope, you may be dealing with epilepsy. So you have to differentiate very, very carefully. And that is why you have to ask how the problem started, that is onset, and then duration. Duration is of paramount importance. And what are the aggravating factors? What are the associated symptoms, like say tinnitus, hearing loss, vomiting, sweating? A word about tinnitus again. Tinnitus is jerky to and fro involuntary movement of the eyeball. Otherwise, it is called lack of ocular posture. Why we are concerned with tinnitus when we are dealing with vertigo? Because vestibular nystagmus, that means vestibular disorders, they are very, very commonly they produce tinnitus. In other words, vestibular problems, they are most common cause of tinnitus. And classically, the vestibular nystagmus has got a slow component and a fast component. They are associated with vertigo when compared to nystagmus due to other regions like ocular causes, central nervous system causes, and so on. Why did I say duration is most important as far as the vertigo is concerned? If the vertigo lasts for a few seconds, it is benign paroxysmal positional vertigo, or it may be a case of perineal fistula, or it may be a case of cholesterol protein fistula. If vertigo lasts for a few minutes, maybe migraine, facial migraine, or pathological migraine, or vestibular migraine, and or maybe vestibulobasilar insufficiency (VBI). If it lasts for hours, then it must be vestibulopathy or Meniere's disease. If it lasts for days, it may be vestibular neuronitis or it may be a case of labyrinthitis. If vertigo lasts for weeks, then you must consider a central nervous system cause like multiple sclerosis or an acoustic tumor, and last but not the least, the psychogenic tinnitus. Now, how do we proceed to examine these patients? First and foremost is examine thoroughly the ear, nose, throat, and neck very thoroughly, including the cervical spine, and also all the cranial nerves must be examined. And then look for spontaneous nystagmus. Just put your finger opposite his eyes and make a small movement. And watch his eyes, whether you are able to see any nystagmus. If there is nystagmus, you watch whether what is the direction of nystagmus, what is the form of nystagmus, whether it is changing with fixation of the eye. If the direction is fixed, there is no direction changing, it must be peripheral vertigo. What is peripheral vertigo? Vertigo because of the otological reasons, otological cause. If by any chance the nystagmus is direction changing, it must be from the central nervous system. In the same way, if the vertigo, the form of the vertigo is jerky, it is peripheral nystagmus. If it is pendular, then it must be central. And if the vertigo it is suppressed with fixation of the eye, then it is peripheral vertigo. If it is enhancing with the fixation, then it must be central vertigo. Then you have to look for smooth pursuit. You can look for the smooth pursuit, and there is smooth pursuit. What is smooth pursuit? Smooth movement to track a moving object, like athletics on a moving ball. And you also have to see for any saccades, that is rapid eye jumps, bringing focus from one object to the other. The saccades may be dysmetric, that means they are not uniform. Then they must be cerebellar in origin. If they are slow saccades, they must be brainstem in origin. And the saccades are late saccades, they must be frontal lobe in origin. And if they are disconjugate, it must be the multiple sclerosis that is responsible for it. And you have to do what is known as EPELEY'S, that is head impulse test. Take the head of the patient and tilt it like this, shake it as you shake a bottle, and look for the nystagmus. If there is horizontal nystagmus, then it is peripheral. If you find vertical nystagmus, not the central in origin. Most likely brainstem. And you can do this dynamic visual acuity if there is more than 3 lines drop, then it must be vestibular loss, bilateral vestibulopathy. And you can do a position test. We'll tell you how to do a position test. If you do a position test and if it is positive, it must be either benign or malignant positional attack. And the cerebellar signs, all of you know. What are cerebellar signs? Finger nose test and dysdiadochokinesis. What is dysdiadochokinesis? Failure to do alternate movements like this. And you have to also look for tremor, cerebellar tremor. What is cerebellar tremor? Cerebellar tremor is intention tremor when compared to the tremor due to Parkinson. Parkinsonian tremor is tremor at rest, whereas cerebellar tremor is intention tremor. And classically, there will be cerebellar speech, otherwise known as staccato speech. And you can do a Romberg test. You know how to do a Romberg test. Just make the patient stand and ask the patient to close his eyes. If he's faced to one side, that must be, patient must be having a lesion in his cerebellum or in the posterior column on that particular side. To which side he is faced. And Uterburger's test, otherwise known as Fukuda stepping test. How do we do it? Ask the patient to stand up and do something like an exercise with eyes open and eyes closed. If the patient closes his eyes and then he doesn't stay at the same position and the base changes, he must be suffering from vestibular pathology. Coming to various conditions, like first condition is acute vestibular failure. Acute vestibular failure is unilateral generally, like the picture will be like that of a labyrinthectomy. Suppose you have to destroy labyrinth. Say, for example, you are doing a translabyrinthine acoustic neuroma surgery. That means you have to destroy labyrinth and go beyond. So, patient will suffer from acute vestibular failure, and invariably he must be recovering in a period of 6 weeks. And positional vertigo also, we should know already, I have mentioned, it is concerned with the position of the head, and generally it is of short duration. And what about the compensation from vestibular lesions? Compensation is very, very common as far as the vestibular lesions are concerned. It is early if the patient is younger, and it is early in peripheral lesions than central lesions. It is compensation is early if it is a unilateral lesion rather than a bilateral lesion, and if it is static, if it is early in case of static lesions rather than dynamic lesion like venous disease. We can study the vertigo in 4 groups. First is positional vertigo, second is isolated vertigo, third is vertigo associated with deafness and tinnitus, fourth is vertigo associated with neurological signs. First is the positional vertigo. How do we know whether the patient is having positional vertigo or not? Do this Dix-Hallpike maneuver. Make the patient lie down on a couch, and you gently bring the head beyond the edge of the table and gently tilt the head towards the right side, and ask whether the patient feels any reading sensation. And you also look for any evidence of nystagmus. If there is vertigo or nystagmus, position test is positive on the right side. Now wait for a while, bring the head to neutral position, and do the same. Make the patient sit again, and then bring to the lying down posture again. Repeat it to the opposite side. Again, you look for it. If this side is positive, that means position test is positive on the left side. This left side posterior semicircular canal is affected. Here it is right posterior semicircular canal is affected. Now, what is the actual pathology? There are calcium carbonate crystals in the utricle. Due to some reason or other, these calcium carbonate crystals, they get displaced and they come to the posterior semicircular canal. Then this benign paroxysmal positional vertigo results. As the word implies, it is benign, that means it is harmless. It is paroxysmal, that means it occurs in episodes, and it is peripheral, that means it is not a central organ, vertigo or reading sensation. Classically, this vertigo has got latent period, and very classically, this nystagmus is fatigable nystagmus when compared to malignant positional nystagmus, which is non-fatigable. And as a rule, the nystagmus will stop after 30 seconds. How will you treat this? By doing what is known as EPELEY'S maneuver. What is EPELEY'S maneuver? EPELEY'S maneuver is the maneuver by means of which these displaced calcium carbonate crystals from the utricle, they are brought back into the utricle. These displaced calcium carbonate crystals, they are in the tubula of the posterior semicircular canal. They are brought back into utricle. How? See, now make the patient lie down on the table and hold the hands. Turn towards the right side. Then you turn the head by 180 degrees to the opposite side. Then you make the patient lie down in the prone position. With this, gently the displaced calcium carbonate crystal will go back to its original position. This is EPELEY'S maneuver. This is extremely gratifying. Patient doesn't need any drug treatment. With this maneuver itself, patient will be improving. If patient doesn't improve, he can continue doing this. And another cause of disequilibrium, we don't call it vertigo, it is something like unsteadiness. That is disequilibrium of aging. This is just like presbyopia, presbyocusis. This is presbyopia. That is because of the aging, there will be degeneration of the specialized nerve elements in the macula and crista. You can treat the patient with lateral sedatives. Sometimes the cervical collar also helps. As I already mentioned, in comparison to the benign paroxysmal positional vertigo, there is what is known as malignant positional vertigo. Malignant, the word malignant here is not cancerous, it is dangerous. Why? Because this is due to a cause in the central nervous system, that is the brain. It doesn't have a latent period. It is non-fatigable nystagmus, and it may be indicating a tumor inside the brain or a brainstem, or it may be indicating multiple sclerosis, or it may be because of some vascular lesion. Coming to the conditions where there are isolated vertigo, only vertigo is there. First and foremost is vestibular neuronitis. What is vestibular neuronitis? Vestibular neuronitis is because of the infection of the vestibular nerve by means of some virus. Lot of viruses they are playing, like Epstein-Barr virus, and very classically patient will have an upper respiratory tract infection, and there may be fever, there may be cold, and suddenly patient develops severe vertigo and vomitings. It is continuous, and it lasts for days together. So with the history, you can suspect this. If you do cold calorie test, CCT is cold calorie test. How will you do cold calorie test? Make the patient lie down on a couch and you tilt the head anteriorly by 30 degrees. Why? By tilting the head by 30 degrees or by elevating the head by 30 degrees, you are making the horizontal semicircular canal truly horizontal. Now, you irrigate the air by means of cold water. That is, what is the normal body temperature? It is about 35 degrees or so. So, if you irrigate the ear canal by means of warm water at about 41 degrees, there will be nystagmus. That means the range of temperature is felt or carried into the inner ear by conduction and convection currents. in the inner ear fluids, and vestibular labyrinth is stimulated, and the nystagmus appears. If you reduce the temperature of the irrigating liquid by 7 degrees, say 30 degrees, that means you make it cool. Then it is cold Kelvin test. Previously it is warm Kelvin test, cold Kelvin test. If you do it, you will see canal pencils. That means you will repeat the test on both sides and compare with both sides. So the pathological side, there will be poor response. Sometimes the vertigo may be because of disseminated sclerosis. Disseminated sclerosis, there will be other signs like, say, pyramidal signs or painful palsies and so on. And certain drugs like, once again, aminoglycosides, estrogens, especially the estrogens that are given by the gastroenterologist for postponing the menstrual cycle and all, or the caloritanic pills, they are all notorious in producing vertigo. And diuretics, which I already mentioned, the fusimide, the catalytic acid, and so on. And the cotrimoxazole, that is Cetron, and metronidazole, that is Flagyl. And certain miscellaneous conditions like anemia, diabetes mellitus, migraine, and psychogenic causes. They also produce vertigo very, very commonly. As the time is up, we will continue in the next class. All the best.